Welcome back to the Masterclass, everyone. I'm your lead instructor, Harshal, and today we are setting the stage for something absolutely crucial. We're going to decode the architectural foundation of the entire hospital reimbursement engine, the IPDRG system. We're looking at exactly how raw diagnosis and procedure codes drive the grouping logic to figure out inpatient payment. This is part 38 of our Explainer series, and honestly, it's a fundamental building block for everything we're going to do moving forward. But before we go any further, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal.
All right, let's do a super quick recap of part 37 to get our bearings. Last time we went over the ancillary sections of our coding manuals, specifically looking at imaging, radiation, and rehab. Now, we established that practically all inpatients undergo some form of ancillary testing, right? We're talking x-rays, lab work, CT scans, that sort of thing. But here is the critical takeaway from our sources. Ancillary tests are not assigned ICD-10 PCS codes during an inpatient admission. They just don't drive the grouping logic the way therapeutic major surgical procedures do. And keeping that distinction in mind is actually the perfect bridge into our focus for today.
So here's our agenda for this explainer. First, we'll cover what an MSDRG system actually is. Second, we'll look at MDCs and the surgical versus medical partition. Third, we'll dive into severity level tiering, your NOC, CC, and MCCs. And finally, we'll wrap up with a summary and next steps.
Let's jump right into section 1. What is an MSDRG system? We're kind of taking a peel the onion approach today, so let's start with the broad container. What exactly is an MSDRG? Well, it stands for Medicare Severity Diagnosis Related Group. According to our sources, you can think of it as a massive statistical sorting system used by CMS to classify hospital inpatient stays into specific groups. The whole idea here is grouping patients together who have similar clinical characteristics and who are expected to consume a similar amount of hospital resources. This one single group determines the fixed payment amount a hospital gets under the Inpatient Prospective Payment System. So it's clinical similarity plus resource similarity rolled up into one payment group.
You might be wondering, how does the grouper software actually know which bucket to put a patient in? It all relies on the clinical documentation that medical coders extract directly from the patient's chart. These are your core inputs. First, you've got the principal diagnosis. That's the condition established after study to be chiefly responsible for the admission. Then, your secondary diagnoses, which reflect any comorbidities or complications. Next, you have any principal and secondary procedures that were performed. And finally, demographic factors, like the patient's age, their sex, and their discharge disposition. All of these inputs are fed into the logic engine to generate that final MSDRG. Moving right along to Section 2, MDCs and the surgical versus medical partition.
So once those inputs are fed into the system, how does the grouper initially categorize them? Well, the answer starts with the number 25. Based primarily on that principal diagnosis we just talked about, every single inpatient case is instantly dropped into one of 25 major diagnostic categories, or MDCs. These MDCs map out to major organ systems or etiologies. Just to give you an idea, MDC 05 is for diseases and disorders of the circulatory system, while MDC 04 is for respiratory system disorders. This is your very highest level of classification.
Now, once a case lands in an MDC, the grouper logic engine hits its first major fork on the road. It partitions the cases down two totally distinct pathways. The surgical partition is assigned if, and only if, the medical coder has captured an ICD-10 PCS code that meets the strict CMS definition of a major operating room procedure. If no qualifying OR procedure was performed, the case is routed down the medical partition. This split is absolute, and it completely changes the entire trajectory of how the reimbursement is calculated.
Next up is Section 3, and this is a big one. Severity level tiering. No CC, CC, and MCC.
We have officially arrived at the most critical, complex, and honestly the most impactful part of this masterclass, severity level tiering. Within those medical or surgical partitions we just looked at, the MSDRG system refines the categorization based on severity. And it does this by scanning for specific secondary diagnoses. A CC, which is a complication and comorbidity, is a coexisting condition that adds moderate severity and bumps up resource use. Think of something like an unspecified UTI or moderate malnutrition. An MCC, or major complication and comorbidity, points to high severity and a substantial increase in hospital resources, stuff like acute respiratory failure or sepsis. Now, our source documents highlight a vital clinical rule here. To actually be coded, these secondary conditions must actively require clinical evaluation, therapeutic treatment, diagnostic procedures, and extended length of stay, or increased nursing care. You can't just code it if it's sitting in the chart doing nothing.
And as you'll see here, this brilliantly illustrates how those secondary diagnoses impact the bottom line. The CC and MCC logic creates up to 3 distinct payment tiers for almost every MSDRG family. If the chart has at least one diagnosis flagged as an MCC, boom, it bumps the case into the highest payment tier, which carries the highest relative weight. If there's a CC but no MCC, it lands in the middle tier. And if there are no secondary diagnoses flagged as either a CC or an MCC, it drops right down to the lowest base payment tier.
Let's make this abstract concept totally concrete. Take a look at this classic example from our source material, the heart failure DRG triplet. Check out DRGs 291, 292, and 293. They are all for patients admitted with heart failure and shock. Literally, the only difference between them is the severity tiering driven by those secondary diagnoses. DRG 291 is with MCC, that's your highest severity. DRG 292 is with CC for medium severity, and DRG 293 is without CC or MCC for the lowest severity. Capturing just one single MCC condition completely changes the final DRG assigned.
So to really prove why this matters, let's do the math and look at the financial stakes. The hospital payment formula is actually pretty straightforward. It's the hospital base rate multiplied by the DRG relative weight, which gives you the final payment. Let's say a hospital has a base rate of $6,000. If a patient is grouped into DRG 291, that heart failure with MCC group we just discussed, the relative weight is 1.3. So $6,000 multiplied by 1.3 yields a final payment of $7,800. But if the medical coder misses the MCC, say they forget to query the physician to clarify a diagnosis of acute renal failure, the relative weight drops significantly, and the hospital literally loses legally entitled revenue. That, right there, is the power of accurate severity tiering.
Now hold on, because there is a massive real-world caveat we have to talk about, the present on admission or POA rule. Our sources give a fantastic example of this. If a secondary diagnosis develops after the patient is admitted, meaning it gets a POA indicator of N, it often cannot be used to increase the DRG weight. For example, if a patient is admitted and 2 days later they develop a new deep vein thrombosis or DVT, that DVT is considered a hospital-acquired condition. Even though a DVT is technically an MCC, because it was acquired in the hospital, CMS rules strip away its MCC status for payment purposes, dropping the patient right back down to a lower paying tier.
Okay, wrapping things up with Section 4, Summary, and Next Steps. Let's just quickly retrace the entire journey of a medical chart through the grouper. Step 1, the principal diagnosis establishes your major diagnostic category. Step 2, the presence or absence of a qualifying major or procedure directs the case down either the medical or surgical partition. And Step 3, the presence of specific actively treated secondary diagnoses dictates the final severity level tier, whether that's no CC, CC, or MCC, which ultimately drives the relative weight and the final reimbursement.
So, where do we go from here? Next time in Part 39, we're diving deep into principal diagnosis selection rules. We'll be examining the official inpatient guidelines and coding clinic logic to make sure you always select the rock-solid foundation for your DRG. If you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Until then, I'll leave you with this thought. If capturing just one secondary diagnosis can alter hospital reimbursement by thousands of dollars, how much revenue do you think is slipping through the cracks right now due to incomplete clinical documentation? Keep decoding, and I'll see you in Part 39.